We're at noon, so we're going to go ahead and get started. It is my pleasure for our Roy Benke Department of Internal Medicine Grand Rounds to introduce Dr. Phil Altus. Dr. Altus arrived in 1976 to our great program, and he was joking yesterday at Morning Report that when he arrived, the first winter that he was here, snow hit the Tampa Bay area, as you learned from my Grand Rounds a couple weeks ago. So he said it was something out of biblical proportion. Altus comes, and here comes the snow since Dr. Altus is from Albany. Well, we haven't had snow since, but maybe this Grand Rounds is a harbinger of that we'll have snow this winter. We'll see. Dr. Altus became formally program director in 1980, proceeded for the next 25 years to run our Department of Internal Medicine, General Internal Medicine residency. I know I came here very impressed by watching Dr. Altus give morning report. I talked to him a little bit after I interviewed with Dr. Flannery. Dr. Flannery, who was his right-hand man for a long, long time, was an incredible force in this program. And really it's a reflection of the great leaders Dr. Altus has been able to train. You know, folks here who had him in clinic. Jeff Cooper is here, John McCormick, so many who had Dr. Altus in clinic have learned and continued their, as we call them, Altuisms, which are his favorite little phrases that you will hear probably during these grand rounds. Dr. Altus was instrumental in what is now Doctor's Dilemma at the American College of Physicians. He challenged Georgia in the old Florida Georgia tradition, challenged Georgia to a best champions of each state face-off, which then grew to be what is today Doctor's Dilemma, which has 70 teams, 70, Phil, at the last ACP national meeting in Boston. I couldn't believe it when I saw 70, and to think that Dr. Altus started it with just 2 folks. He was named Master of the American College of Physicians. We've only had 3 masters in the whole history of this program, and one of them was the founder, Dr. Roy Benke. So this is really a great distinction. Dr. Altus served many years on major committees, and it is a pleasure to bring our Professor Emeritus back here. Phil Altus will talk about 55 years in the art and practice of internal medicine. Thank you, Phil.
Thank you, Joe. It's a privilege and an honor to be asked to speak in the Roy Benke lecture series. This was an incredible man, as Dr. Lozama has mentioned, who came in 72. I came down here in 76, and I was, I think, the 26th full-time faculty member. And of all 26 of us, we had just incredible loyalty and respect for that man. And I don't know of any of us who would refuse to walk over hot coals for him. He was just a terrific guy and a mentor and a father figure to all of us. And it's a nice legacy that these grand rounds are named after him. I'm going to talk about, as Joe said, 55 years because, you know, sometimes I remember 55 years ago better than what I had for breakfast, but that's what happens when you get old. Well, I started this by saying it was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. And I have to give credit to Charles Dickens. That's from The Tale of Two Cities. But that also describes the last 55 years of internal medicine. 1968, I was a second-year medical student and was using my required microscope in histology and pathology labs to look at slides. My class demographics, there were 107 students, 98 were Caucasian men, 9 were Caucasian women. At the end of the first year, 4 of the women had dropped out. So we are now down to 5 Caucasian women. All students attended all classes, no note services, then wore ties and jackets or sweaters because we were up north. Women wore dresses or skirts. In pharmacology, we learned about digitalis, a drug probably nobody uses anymore. Streptomycin, another drug that is gone, and a new antibiotic that was going to get rid of gram-negative infections forever. That was gentamicin. Medicare was 3 years old. What were we taught? Well, there were no computers, CAT scans, MRIs, echoes, ultrasounds, colonoscopies, flexible bronchoscopies, sigmoidoscopies, or pulse ox, and probably more importantly for you, there were no smartphones. So you didn't have one of these things. What we did learn was how to do a complete history and physical from outstanding clinicians. We were taught how to logically solve problems, think about things. Compassionate care, doctor-patient relationships were emphasized. Well, let me bring you back to 1968. I was a second-year student. I was doing physical diagnosis, learning how to listen to hearts. I went to see a 65-year-old woman who had been bedridden for 6 months. She hurt all over, could not get out of bed. Nobody knew what was going on. I presented this case to my mentor. She had slight anemia and increased platelets. My mentor was a renal fellow, okay? He jumped out of the chair, and said, I just read about this last night. This lady has polymyalgia rheumatica, a newly described illness. We all took off and raced to the wards, told the house staff. They put her on prednisone. The next day, she was walking in the halls pain-free. So what's the teaching point about this? Well, it's critical to read the literature. Medicine is about constant learning. I've been retired for 20 years now, and I still read medicine because I love medicine. I get things daily on the computer from Medscape, from MD links and stuff, and I'm fascinated by this stuff. This is fun. This should not be work. It's also important to read about diseases outside your subspecialty. So many people get sort of narrowed into everything is cardiology, everything is GI, but you ought to know a little bit about other things. You don't have to be an expert, but at least know something about them. 1971, I started my residency. Our CCU had 8 beds, and our ICU, which we shared with surgery, had 14 beds. No one was admitted to these units who had a terminal disease, who was over the age of 70. That gives me cause for concern. Dialysis was reserved for patients eligible for transplant. If you weren't eligible for transplant, tough luck. Diabetics, the elderly, cancer patients were excluded. We used a PDR. Those under 35 probably don't know what a PDR is. It's called a physician's desk reference. It had a list of all the medications. We used the Washington Manual. Again, you've never known what that is. That was a book that was put out by WashU School of Medicine in St. Louis. It told you it was your iPhone. It told you how to treat patients. And every year, the chief resident at WashU, their job was to update the Washington Manual. We used Index Medicus, another thing you've never heard about. This was a big book. If you wanted to find papers on a topic in the literature, there was no Medline search. There were no computers. You went to a library and got one of these big books and started looking through that. And we were often found in a library. And if you don't know what that is, that's a big building with books, okay? And one of the key things is not only do we spend a lot of time learning, but we spend a lot of time socializing there. Face-to-face socializing, not looking at your phone on Facebook type of thing. Private internists in the community often made ward rounds for a month. They were giving back to the next generation, teaching them how to practice medicine. Well, some of the medications available, these you probably have almost heard of none of them. For hypertension, we use reserpine, hydralazine, thiazides, and aldemed. Probably the only one you've ever used today is thiazides. Cardiac medicine, digitalis, quinidine, and procainamide. Antibiotics, drugs you've never heard of. Penicillin, ampicillin, we still use sulfa, tetracycline, streptomycin, kanamycin, all these mycins. Colistin, chloramphenicol, a great drug, which unfortunately in some people cause aplastic anemia. Cephalothin, the first cephalosporin, and gentamicin, but you need an ID to say it's okay to use that. There were rules that we thought. All orders were written by the primary house staff team. Okay, not by the attendings, not by the consultants. And this was critical because it created dialogue between the residents, the consultants, the attendings. You knew what people were thinking, yeah, it wasn't, you know, the elephant in the room where everyone's picking out something differently. I, as a house officer, was totally responsible for my patients, obviously under the supervision of my attending. And today I look at a good internist as being basically the point guard or the quarterback or the orchestra leading, directing the whole show and getting rid of this piecemeal care. Advocacy for our patients was stressed. This is something that is absolutely critical, and I'll get to some of this in a minute. Clinical skills. My chief of cardiology was Bob Ike, terrific guy. He often said, when all else fails, examine the patient. He would pass through the CCU late in the afternoon and look at me and say, Phil, watch out for patients in bed 2 and 7, all the others are fine. And he was always right. If somebody crashed, it was 2 or 7. Everybody else sailed through the night. He would predict mitral stenosis severity based on the opening snap. Again, there were no echoes back then. There were cath, but no echoes. You don't see mitral stenosis anymore, luckily, because rheumatic fever is a thing of the past. But he would also predict the severity of aortic stenosis by feeling the carotid upstrokes. And he was already right when these patients went to cath lab. Once a month, he would go up to the Northland in upstate New York, and he'd say to the residents on cardiology, you want to come with me? And say, sure. He said, well, you got to get up at 5 o'clock. No problem. We're on our way. And there would be like 50 kids with murmurs. You know, kids have murmurs. And he would listen to them and say, you go over there, you go over there, you go over there. And about 3 or 4 of them he would pick up that had rheumatic heart disease, rheumatic valvular disease problems, and bring those back down to Syracuse for a heart cath. He also told us it was okay to change your mind at any given time. And that's absolutely critical. Okay, you've got to look at new data and be willing to change. You know, one of my old good friends used to say, you know, the physicians say, don't confuse me with the facts. Well, yes, confuse you with the facts, change your mind if things change. And I'll show you how some things have changed. Here's a case. And this case proves a few things. 35-year-old woman was admitted with left-sided pleuritic chest pain for 24 hours. She took birth control pills, smoked, had a low-grade fever, and a nuclear medicine lung scan, which we used back then, was highly probable for pulmonary embolus. Her PO2 was 74. Dr. Obaid, one of our other cardiologists, who had an ear that rivaled a dog's ear. He could hear anything. He examined her and said, we need to get a pulmonary angiogram on her. We looked at him and said, why? He said, Phil, did you listen to her second heart sound? I said, well, yeah. He said, it's soft. She should have a loud second heart sound. The study was negative, which was the gold standard. The diagnosis was changed to viral pleuritis. She was discharged and did well. Now, there's a couple of points I want to make about this. Dr. Benke was famous for saying, you never learn off of clean sheets, meaning you got to have a bunch of patients. I don't have a slide of this, but let me fast forward this to 2004, right before I retired. I was ward attending. Wade Weaver, who some of you know, was the resident, damn good resident. He admitted on a Friday night this 30-year-old pizza delivery man who came in with lower left-sided chest pain, had a pulmonary CT, which is high probability for pulmonary embolus. So I come in Saturday morning to make rounds. I see this guy. His respiratory rate is 16. His heart rate is 70. I said, what do you do? He said, I deliver pizzas. I get out of my car, walk in, walk out. I listen to his heart. I didn't hear his second heart sound either. But I said, Wade, I don't think this guy has a pulmonary embolus. I think you need a pulmonary arteriogram. See, I learned off the clean sheets here from 30 years before that. And I said, I wrote a note and I said, if you have a problem, call me up. 2 hours later, he called me up and he said, the radiology resident came back, reviewed the scan, said, he doesn't need an angiogram. This is all okay. I said, Dr. Benke's one of his other famous statements is, it's okay to be appropriately, and that's in capitals, arrogant. I said to Wade, tell the resident your attending has written a note in the chart saying he needs an arteriogram. and he should discuss that with his resident, his attending. 2 hours later, Wade calls me back and says, guess what? The arteriogram is negative. I said, fine, send him home. The guy comes back the next day with a bleeding peptic ulcer. And that's what was causing his pain. So I wonder how he would have done on heparin. So again, learn from all your other cases, okay to be appropriately arrogant. One night we admitted 15 patients. You can't do that anymore. One man had an upper GI bleed. Interestingly, he also had a history of situs inversus. I said to the intern, listen, we got a lot of patients. Make it quick. Just tell about the GI bleed. Forget about that. Our attending was Dr. Streeton, a really iconic endocrinologist. He was from South Africa originally. He presented the case. He went to the bedside like a good attending, examined the patient, and went, and he looked up at me and said, Phil, you didn't tell me this guy had dextrocardia. An endocrinologist picking this up. Working together. Like I said, we all work together. I remember right before I came down here, we had a 58-year-old lady transferred to our medical center who had unstable angina and severe hypothyroidism. She was sent in so we could do a cardiac cath and fix her. Well, cardiology said any surgery with her mixed edema would kill her. So we said, all right. We walked in the room, gave a very small dose of thyroxine, and she developed horrible angina. So he said, well, let's give her a little beta blocker. So we gave her 10 milligrams of propranolol, and her heart rate was 35 and her blood pressure was 90. So I remember my old algebra teacher or somebody in school said, but gosh, it can't be factored, type of thing. And we said, this can't be solved. What are we going to do? Well, Dr. Ike and Dr. Streeton got together and said, how are we going to fix this? The endocrinologist came up with a novel approach. Let's put in a temporary transvenous pacemaker, set the heart rate to 55, give her some beta blocker, and get her beta blocker up. The pacemaker will keep her heart rate going, and then we can give her thyroid. And lo and behold, it worked. She went for her cabbage and lived happily ever after. Well, at least she walked out of the hospital. I don't know how long she lived. So there were some key learning points back then for my residency. Always do a complete history and physical. The patient needs to be undressed. I can't tell you how many times I've worked with residents and they examine patients through their shirts. You cannot hear subtle things through a shirt, okay? Your patient is your responsibility and you need to be captain of the ship. The pathophysiology never changes. Since we walked out of the caves, things have continued to work. Our understanding changes, but that has not changed. Always step back and think, ask questions to both yourself and others, and don't be afraid to say, I don't know. Medicine changes. Read a journal and get good CME. Think outside the box. Here's another quote from one of my other mentors. If it's intuitively obvious, 50% of the time it's going to be wrong. I remember my first day of medical school, our beloved dean addressed the freshman class, and he said to us, 50% of what we tell you is and teach you is going to be wrong. The only problem we have is we don't know which 50% that is. Well, here's some examples. We used to preach in the old days that estrogens are cardioprotective. After all, women are protected until they go through menopause. Then they have heart disease and everything else. We know that's not true. Antiarrhythmics decrease sudden death. We know that PVCs can lead to VFib, and VFib leads to a funeral. Okay? So if we got rid of the PVCs, we could get rid of sudden death. Well, that didn't work out. A bunch of studies looking at getting rid of PVCs, and they got rid of them, more sudden death. Beta blockers are bad for heart failure. When I was a resident, you would be thrown out of the program if you gave somebody with heart failure a beta blocker. Now we know that's standard of care type of thing. Here's an interesting thing for you. And this is, again, we got to think a little bit outside the box. We take a patient with hypertension and we give them medications and we lower their blood pressure to 120/80. Okay? That patient is still at significant risk because the blood pressure as one of the icons in hypertension used to say, is just a marker for something going on under the surface of the water. And if you want to play games, pull up the Framingham risk model and plug in what they want you to do, lipids, diabetes. Put in blood pressure 140 over 90. Put in treated hypertension 120 over 80. Who has the highest risk? The treated hypertensive who's 120 over 80. And this comes from thousands of patients followed for a long period of time. All right, other things. When does diabetes start? We all think, well, it starts when you get a blood test and the blood sugar is 200. Well, no, it doesn't. It actually starts about 10 years before the blood sugar becomes elevated. It's related to insulin resistance, which is most likely related to visceral adiposity. And you can look at patients and you can see increases in triglycerides, lowering of HDLs, increases in blood pressure, all things with insulin resistance. When the glucose is still normal because your pancreas is pumping out more and more insulin until it poops out, insulin levels drop, glucose rises. And I said at one of Dr. Lozama's conferences, I remember in 1977, Dr. Norman Siperstein, endocrinologist from UC San Francisco, presented data showing that if you take a newly diagnosed diabetic and biopsy their quadricep muscles, you will see thickening of the basement membrane, which is the hallmark of diabetes, in 90% of the patients at the time of diagnosis. That's why you have to go after the people who have impaired glucose tolerance, the metabolic syndrome people, the so-called pre-diabetic people, and go after them with diet and exercise. And there's really good data that you can delay the onset of frank diabetes and hopefully delay the complications. Well, let's look at a few things back then and now. Breast cancer, 1970s. Women with breast cancer came to the hospital, had a modified radical mastectomy. They removed the entire breast, some chest wall muscles, lymph nodes, stayed in the hospital 7 to 10 days. Here's one of my patients in 2000, Mrs. C. She had a positive mammogram. She was 78. She had a lumpectomy and sentinel node biopsy, all under local anesthesia. A frozen section, the sentinel node was negative. Dr. Cox, who did this, said, well, if you have good support, you can go home. If you want to stay overnight, you can do that. She said, my son came in to take care of me. I'll go home. Last October, she was 103. Okay, an incredible difference in what happens. What about cardiology? When I was a resident, if you had an acute coronary syndrome, you came into the CCU. If an MI was ruled out, you were sent home in a few days. God forbid you come in on Friday because you couldn't get the results of your CPKs until Monday. So the patient was sitting in the CCU for 3 days, whether they had an MI or not. But if you had an MI, you stay in the hospital 3 weeks. Okay? Dr. Bogner probably remembers that from the old days. The treatment was oxygen, morphine, lidocaine, digitalis for heart failure. Nitrates and beta blockers contraindicated. They were killing people. Now, what do? You give them nitrates and beta blockers. Heparin in a few people to prevent DVTs. What about now? Come into Tampa General ER. I got acute chest pain for the last hour. Up to the cath lab. Boom. Open it up with a stent. You get nitrates, beta blockers, thrombolytics, antiplatelets, antihypertensives, statins, and you go home in 2 days. And more importantly, you have preserved myocardium. You don't get left with congestive heart failure. And what we've learned over the years, and I've been a proponent of this and preached this forever, is that actually plaque inflammation may actually be more important than your cholesterol and your LDL. We all have plaques because we've all eaten bad stuff growing up, okay? But you don't want your plaques to rupture. And in fact, most MIs don't occur from those 80% plaques. They occur from plaques that are less than 50% that acutely rupture. Well, how about now with cardiology? This is another one of my patients. I have a long history in a lot of patients. Dr. W, great guy. A patient of mine, he had significant stable angina, intolerant to beta blockers or nitrates. He had a tight lesion in his diagonal, which Dr. Bowerman, some of you know from the VA, stented, and he did okay. actually angioplasty. They didn't have stents in those days. 3 years later, he's at a meeting in Seattle. He had an acute coronary syndrome. They whisked him right across from the hotel to the hospital, and he had a successful angioplasty of his circumflex. 3 years after that, he calls me on a Sunday morning. He's in New York with one of his girlfriends. He had 3 girlfriends all over the country. He said, I've been having chest pain for the last, 10 hours or so. You think it's okay to fly home? I said, no, get your butt into the hospital. And he had a successful angioplasty of his right coronary artery. 4 years later, he lived over in Clearwater, and he said, I'm having some chest pain. And he said, now, I've already chewed a couple of aspirin, because he knew what the hell. I said, get your ass in here right away. He comes into Tampa General, had a successful angioplasty of his LAD, 3 different vessels. When I retired, he was 90 years old. He was angina-free, and he had a normal ejection fraction, no cardiac symptoms, no signs of heart failure or anything else. That's progress. Here's some interesting new data. This is was published in the last few months. 18,000, big study. 811 patients who had a stent for a STEMI were followed with guideline therapy and matched by age and gender with 94,000 patients who had cardiovascular disease who had not had a PCI. And what they found is if they had lived 90 days after their procedure, there was actually no difference in mortality at 10 years. So the medicines really do work. And it's something you got to put in now. You got to make sure that the patients are on good doses and that they take their medicine. Let's look at hem-onc. Back in the old days, ALL was almost always fatal. Today, it's 95% curable. Hodgkin's disease was often fatal. Now it's mostly curable. Lymphoma was always often fatal. Now many cases are cured. Metastatic testicular disease was fatal. Now many are cured. Promyelocytic leukemia, M3, was acutely fatal within a couple of months. Now it's treated with the all transretinoic acid drugs with pretty much normal survival. CML was fatal. Now it's treatable with tyrosine kinase inhibitors. Colon cancer was often diagnosed with symptoms of obstruction and all sorts of other things, a heme-positive stool. Now, if you do colonoscopy and take out the polyps, you can prevent it, basically. Some people with metastatic melanoma, which was a quickly fatal disease, are responding to immunotherapy. And keep in mind Jimmy Carter, the poster boy for that. And mammography is picking up smaller, earlier tumors, and limited surgery and sentinel nodes are making a big impact in breast cancer. Infectious diseases. In the 70s and 80s, diagnosing infectious diseases took forever. While there were limited antibiotics, you could often find one that worked. 50 years ago, there was no C. diff, Legionella, Zika, but we did see interesting malaria from the soldiers coming back from Vietnam, and sequelae of rheumatic fever, which, luckily you don't see anymore. HIV in the 80s was a fatal disease. Hepatitis C had no treatment. How about now? There are resistant organisms from those antibiotics that we use, MRSA, VRE, and others. There are diseases that tend to be iatrogenic, like C. diff. PCR enables rapid diagnosis, shorter and less intensive treatment for pneumonia, UTIs, and tuberculosis. HIV is a chronic disease. If you have a patient who's compliant with their medicine or adherent with their medicine and can get their medicine, hepatitis C can be cured in maybe 90% of the patients with our drugs. And we have immunizations for varicella, zoster, HPV, Hep A, Hep B, H flu, pneumococcus, and COVID. Peptic ulcer disease, back then, 90% of the GI bleeds were treated on the floor. Now they all go to the unit. Treatment was alternating milk and Maalox every hour, okay? Recurrences were treated surgically. And the cause, everybody knew, was too much acid. 2018, most patients with bleeding go to the ICU. Treatment are PPIs or H2 blockers. Surgery is extraordinarily rare. And now we know that one of the major causes is H. pylori, and it's really an infectious disease, not a GI disease. How about stroke? Prior to effective blood pressure control, stroke was very common. When I was a resident, we always had 5 or 6 stroke patients on our wards. Treatment was bed rest and a little PT. Mortality was high. And keep in mind the three leaders in World War II, Roosevelt, Churchill, and Stalin, all died from hemorrhagic strokes. How about now with better antihypertensives and emphasis on blood pressure control, as well as statin use? And the statins are, their benefit in stroke is more preventing the inflammation and plaque rupture in your arteries rather than lowering cholesterol. The incidence of stroke has decreased. Effective anticoagulation has reduced stroke from AFib. Early signs of stroke have been taught, so patients can come in, get thrombolytics or have a thrombectomy, and do quite well. Some of the advances in medicine. We've seen the Bronze Age, the Stone Age, the Renaissance, the Industrial Revolution, but now we have the tech age. During my career, I saw the development of computers, chips to power everything, CT, MRI, echoes, ultrasounds, telemetry, PET scans, smartphones, you name it. But I have often said a good clinician should not be a slave to high tech, but high tech should work for him or her. And let me show you some examples of this. 30-year-old man came in to see me complaining of back pain. I'm the third physician he has seen, and I'm his last hope. He's seen an orthopod, neurologist. They've had a CT and an MRI, both of which were, quote, unremarkable. I say, well, tell me about your back pain. He said, it feels like my back is inflamed. Now, I've seen a lot of patients with back pain. This was the first guy ever told me his back was inflamed. He denied any other symptoms, but I kept on asking him questions. How about your activity? Well, I can do things. My back's worse in the morning. I can do things. But interestingly, my wife is pregnant, and I go to the Lamaze classes with her, and I'm the only guy who can't bend over and touch my toes. So then I said, tell me about your father's back pain. And he said, how did you know my father had back pain? And I said, I'm going to send you for an x-ray. He said, I've already had MRIs and CT scans. I said, I want to send you for x-rays of your SI joints. And that's what this man had, sacroiliitis, and he had ankylosing spondylitis. And he told you his back is inflamed. He didn't tell you my back hurts, aches, or anything else. And he's a young guy. It's worse in the morning. His father had back pain. And I immediately sent him to John Carter. 70-year-old woman presents with abdominal pain. This is one of my favorite ones. CT of the abdomen and chest showed a left renal mass and 3 metastatic lesions in her liver. She's admitted to Tampa General for further workup. Her son-in-law was a departmental chair, not medicine, but some other department at USF, and her son was a physician up in Virginia. Her son said, look, mom has 3 mets in her liver. Maybe we ought to just get hospice involved. Mike Flannery, you heard about him. He's on service. This is June. And he tells the team, we need to get a liver biopsy for those lesions, and it comes back non-diagnostic. Well, July 1st starts. So I inherit the team. And I say, we need to repeat this biopsy. People look at me like I'm nuts. Lots of people look at me like I'm nuts. This time, the biopsy comes back purulent material. She is treated with antibiotics with resolution of her metastatic lesions, and she undergoes a nephrectomy at Moffitt, negative nodes, and lives to age 90. Okay. Was this great work by Flannery and me? And the answer is absolutely not. I take no credit for this. A well-trained internist should work this out. Where does renal cell metastasize to most likely? And the answer is lung and bone and not to liver. And her lungs were okay, and she had no bone pain. Her alk phos was normal. Don't be a slave to technology. 75-year-old diabetic man. This was a patient of Dr. Edelman's. Admitted to Tampa General, right upper quadrant pain for 24 hours, nausea and vomiting. Labs, mildly elevated white count, transaminases, bilirubins. Everybody knows what this is, right? Until they do an ultrasound and says negative. No gallstones. Dr. Edelman said, look, you're down in Tampa, can you go see the guy? I said, sure. So, being trained, I put my hands on his abdomen, and the guy jumps. Whoops. Patient's taken to surgery. He has a gangrenous gallbladder, about ready to perforate. Don't be a slave to technology. We went and looked at the ultrasound afterwards. There's no stones, but so what? Now, here's a picture. This is about 2016 or so, taken here at a Heart Association meeting in Tampa. The lady on the left is Debbie Rindy Hoffman, who many of you know, one of our students, residents, cardiology fellows. She's now a big hotshot at LifeLink and stuff like that. The man to her right, on the far left, is Vice President Cheney. And this was about 4 years after he had his heart transplant. He's now about 10 years out. The first heart transplant in the United States was done in 1970 by Shumway in Stanford. The patient lived for 30 days and died. Okay. Transplantation has come a long way from that. I looked at numbers from Tampa General. Tampa General ranks 4th in the nation with number of transplants they do. They're second in the nation in kidneys. They did 459 kidneys in 2020. That's a lot of, that's more than, they're 365 days in a year. Okay. They did 209 livers. That was 4th in the country. They do heart, lung, and kidneys. The first transplant that they did was 1974 at TGH. That was kidney. And since then, they've done 13,250. Right? I mean, incredible. And I have a good friend who got a kidney transplanted in Tampa General, and that was 30 years ago, and he's fine, and his renal function is fine. What makes a good physician? Here comes some of the art of medicine. Is the goal to prevent death? No. We never prevent death, but hopefully we delay death. Then the goal is to prolong life. Well, keep in mind, not necessarily, because life I look at is geometric. It has a length, and it also has a width of life. So it's got a quantity and a quality. And our goal is to provide a long quality lifetime. And I don't think, we put enough emphasis on that. So many people think it's a zero-sum game, you either win or lose. But there's a lot of things you can do to make patients' lives better. Don't drop the ball. Here's another perfect example. I mean, don't get me started. 70-year-old patient, hypertensive, comes for initial visit, had been treated in Michigan, and his blood pressure was okay. He'd been at the Saginaw VA, and he was going to come to Dr. Lizama's VA here, but he heard the wait was very long, so he figured since he has Medicare, he would give me a try. I love this. I'm the trial balloon for these people. I said, all right. His history is negative, except for his blood pressure was 130/84. But when I examined him, without his clothes on, he had a pulsatile abdominal mass. Stat ultrasound, large AAA, came to Tampa General, got a stent placed the next day. I was on consult service, and I said to the resident, I've got a patient here we ought to stop and see. He said, well, he's not on my list. They said, yeah, but he was my patient. Okay, let's make a social visit. And he said to me, why didn't they find this in Michigan? And I asked him, I was in one of my moods, did they ever examine your abdomen? And he said, no, they just asked me questions, took my blood pressure, refilled my prescriptions. Okay. The best of times in the 70s, professionalism. Physicians were regarded highly, probably secondary only to the clergy. Almost all our time was devoted to patient care. There was no paperwork or meaningless chores. I remember being at the VA as a resident. We had a patient who had been there for 4 years, and we would make rounds every other day, and my chart would be 0 delta, okay, no change. That would get me at the principal's office today. What the hell are you writing that stuff for? The relationships we had. We were the captain of the ship. The primary care doctor had a strong doctor-patient relationship, mutual trust. And I can't tell you how many Christmas gifts I got, home-baked breads and cakes, and one lady made me an Afghan and stuff. It was almost embarrassing, some of these things. Volunteerism and a feeling of satisfaction and strong camaraderie. There was really, it was really, I don't want to say it was like the Marines, but we all, it was a band of brothers in those days back. the worst of times. There was limited things that we could do. We didn't, you didn't know things. You couldn't do it. Even if you were great at picking up something, you didn't have the procedures you could do back then. Many physicians worked long hours with little time for their family. The best of times. Well, nowadays, this was 2018, it still exists. Great progress has been made over 50 years. However, many bacteria are resistant to antibiotics. I just read something, there's a new drug that's being looked at now, which has a promise of being able to treat virtually all drug-resistant bacteria because of a totally different mechanism. It's mind-boggling. Obesity and diabetes are greatly increasing. Right now, 42% of adult men are listed as obese in this country. And diabetes is right to follow. Cancer rates are rising. This may have something to do with obesity. Again, my favorite things, insulin resistance, insulin-like growth factor has been shown to play a role in prostate cancer and colon cancer and breast cancer and so many other things. Well, we spend more dollars than the next 4 countries in the world put together in healthcare. The U.S. ranks 110th in life expectancy, 2 spots below North Korea. I guess it's better to have a famine than to have too much food. Part of it is there are 80,000 deaths from opioids, 43,000 deaths from guns. And I saw a statistic just 2 days ago. There's 1 gun fatality every 12 minutes in this country. 50,000 deaths from automobiles, which partially are related to intoxicated people or people under the influence of something. The prices of medication have risen exponentially, and a lot of money is spent on administration. I just read the Medicare has come out with another 10 drugs that they've finally been able to negotiate with pharma to cut the costs. One of these drugs is one of these SGLT2 drugs, which they were paying $576 a month, and it's now down to $167. And you know damn well the drug company isn't losing money on those $167 a month. It's incredible the cost of some of these things. Cost versus benefit. I read about 4 months ago, I keep on telling you, I read this stuff. Denmark will not pay for the GLP-1 drugs for weight reduction. If you have diabetes, that's a different issue. But if you're just overweight, they did a cost analysis, and they found that to save 1 life over 5 years, they're going to cost them $870,000. Okay, get on a treadmill, and don't eat so much. That costs a hell of a lot less. In the U.S., $45 billion is spent on dietary supplements. A recent study published, again in good journals, looked at 390,000 patients taking multivitamins for 10 years. This comes from the nurses' health study, the physicians' health study, and a whole bunch of things. Had no benefit. In fact, there was a slight increase in mortality in the people taking the multivitamins. That's for a different lecture. Here's another interesting thing that's come out just recently in June. If you have patients who've had a PCI with or without ACS, how about stress testing 12 months out? No benefit. If you look 2 years after that. Back in the 70s, internists used to do yearly EKGs, yearly chest x-rays, until that was found to be totally worthless. Now, I know people who get yearly stress tests, not people who have chest pain, but just, we have to check you out, make sure there's nothing a matter with you. That shows no benefit. And in fact, the so-called, a couple of years ago, data was published on the so-called annual physical. That's of no benefit. The complete physical. Just do the routine thing. I know I had a lot of patients who came to see me once and only once because they didn't like it because I didn't do chest x-rays and EKGs every year. And you know how much sleep I lost over that? 0. Here's some other incredible changes. 1968, cataract surgery, 7-day hospitalization. Today, 2 hours, outpatient. Hernia repair, 7 to 10 days hospitalization. I had one. Went in at 5 o'clock in the evening, was home at 8:30, 3 hours. Okay. Total hip, 2 to 3 weeks hospitalization. Now, some are done as outpatients. If you don't want to do it as an outpatient, 2 to 3 days. Elective AAA, people were in the hospital in the ICU for weeks. Now, stent gets placed, watch them overnight. If everything's okay, go home. I mean, incredible progress. I already, mentioned things about gallbladders and all the rest of that stuff, all laparoscopically done quickly. We do have some future questions. Autoimmune and other diseases. We don't have a whole lot of idea what causes inflammatory bowel disease, rheumatoid arthritis, lupus, ALS, multiple sclerosis, Alzheimer's. People are looking at something sooner or later. And I remember my great friend, the late Dr. Nord, used to say the only regret he had was that he won't be alive 20 to 30 years down the line when we'll know what causes all those diseases. Cancer, what's the role of immunotherapy? That's the magic bullet, okay? Rather than knocking out all your other good stuff, just targeting the really bad stuff. And there's a lot of work being done on that. Molecular and genetic therapy, fascinating. I used to, look at things, the genetic therapy. Could we slip in a gene to take out the bad gene in sickle cell disease and cure that? Because it's just, it's a simple thing. And people has developed technology and stuff for that these days. Can we find the right gene and play around without using gene therapy to make everybody 6'2" and perfect weight and whatever type of thing. Cardiovascular disease. Can we prevent hypertension as opposed to just treating it? What about MIs and stroke? The best thing to do as a physician is prevent the disease before it comes up rather than to treat the disease. How can we predict in our hearts who has vulnerable plaques? And there's some data on that with intravascular ultrasound and stuff looking at calcium content and stuff like that. Who should be revascularized? There's a whole lot of people getting stents who don't need stents. Okay, let's target our people who really are at high risk and say, because people get revascularized and they need antiplatelet drugs and then they have all sorts of other problems. The future of this, diabetes, what can be done to stop the obesity epidemic? Here's a question that, has bothered me. It hasn't really bothered me, but I pose. You take the diabetic patients. You got two of them. They both have hemoglobin A1Cs of 7.5. Okay. One person is riddled with complications, the other has none. Why is that? And I still think it's not just the sugar. The sugar is a marker, again. Just like the blood pressure is a marker, just like fever is a marker. And we get hung up on the numbers, but we have to think a little bit more of what's going on under the surface. What causes type 1 diabetes? That's probably another autoimmune thing in a genetically susceptible individual, but it'd be nice if we could work that sort of thing out and at least understanding it. Infectious diseases. How about development of vaccines versus some of the viral diseases, the protozoans, and some of the bacterial agents? People for years have looked at vaccines for bacteria. Could we get like an anti-E. coli vaccine type of thing? Some of the other things. Specifically, molecular targets versus bacteria. I remember, again, a long time ago being at an ACP conference where a man from the NIH was talking about a thing about developing a strain of E. coli that could not adhere to the bladder wall and would knock out the other E. coli because that'd be the dominant E. coli strain. And if it doesn't adhere to the bladder wall, you don't have any urinary tract infections. I mean, that's sort of, 22nd century work on this, but it's sort of an interesting. So in conclusion, what I hope I'd like to convey is that technology has really fueled incredible major advances. We need good design medical research, randomized controlled trials. And that has led to significant improvement in care. So we know what works and what doesn't work. Forget about, well, it's obvious that this should work, because half the time it doesn't. A good history and physical, combined with a knowledge of pathophysiology, logical thinking, and attention to detail, are needed to reap the benefits. And there's no substitution for that. The patient, if you let the patient talk to you, they will tell you most of the time what's the matter with them. Okay? With all the great science, medicine is still an art, and it depends on compassion, good doctor-patient relationship to really maximize the benefits. I thank you for the invitation from Dr. Lozama to come and present this stuff. And I apologize if it just sounds like an old man going back to the old past, but I have great memories. I love medicine, and people say if you really enjoy what you're doing, you'll never work a day in your life. And that's the way I feel about internal medicine and my career. Thank you.